Okay, we're going to start in about a minute. This will be a live webinar that, as you have seen, is translated into Spanish. So you can take the Spanish version. The explanation is in this slide. And so what I'm going to talk about to do is the cycle. Today, I'm going to talk about the cycle 2 evidence-based hormone therapy. I will explain a new postgraduate training program, second part of what I did last year, but I'll try to do it differently in the sense that you will get information of what happens in this evidence-based hormone therapy, where I worked a lot during the summer, got a lot of new things, new information I want to share to you that is really essential also. But I'm going to try to give you a concept that we are, you physicians, you other health professionals, are actually healers, and that this information actually contributes to a better healing with natural products that are in our body. And I will also try to stress the fact that we need to treat the cause, not only the consequences. Just had an email of a person who's very spiritual, but she had an operation because of endometriosis, because actually her hormone deficiencies and other things like dietary problems were not treated. So let's try to put us in our healing cap, and that we have this magic to make things come true. I also want to thank, before I'll start, all the participants of the cycle 1 who have finished their cycle and are going to start now cycle 2, people from all over the world and excellent physicians. I think it will be interesting. I also want to say that we're going to have every month, for those who subscribe, a question and answer session where we'll discuss about patient cases. So now let's go in cycle 2, and again with this idea of we're healers, we're going to try to heal better and have with concepts that make it easier to do so. So the cycle 2 is divided in 8 modules of 39 courses, and there will be special sessions on patient cases that will illustrate among all the modules except on the one on longevity, because I don't have a patient that I've followed up yet 100 years long to be able to tell you how it works out. So the hormone therapy consultation will be the first module with 7 courses and 1 patient cases, and really exciting. I can tell you, I've changed the type of slides. I think they're more interesting, and it will help you to again have this idea: what is the cause of the problems of the patients, and how do I treat it? Because there will be an overview that will be sufficient actually to start working with the treatments. You also know how to interpret lab tests and things like that. So there will be also adrenal hormone therapy, a model on cortisol, DHEA, Aldosterone, and Adrenal. And I'm thinking there's probably the Spanish translation coming into, so please, if you can put it separate. Growth hormone and IGF-1 therapies, there will be 5 courses, and growth hormone, and IGF-1 are probably the 2 major hormones to rejuvenate, or at least to reverse aging and to lessen aging. And there will be also longevity, extension with hormone therapies, 3 courses. And there will also be cardio and cerebrovascular diseases, 7 courses, really intense about what happens with the heart, what happens with the arteries, and also in the brain, and what you can do concretely to solve the situation. And there will be also a model on sexuality. We know that our life is hard, but we need to have pleasure, and our patients too. And this will give a lot of answers. And in conjunction, there will be a session on oxytocin treatment, deficiency diagnosis treatment, and things like that. And this is really a wonderful hormone that I think you should really master its science, because it really can help patients feel better. And then we'll be also about obesity. We know this is the number one health problem in many countries, actually, and what hormone therapy can do. There will be 3 courses and more patient in cases. And so let's look at what will be discussed in module 1, the hormone therapy session. And I need to look if I cannot block a bit these noise that come in now and then. I'm not sure. The hormone therapy consultation has several courses. There's one almost 2-hour course on medical history and actual complaints, where we'll talk about questionnaires, and you'll also have questionnaires to help you in the consultation, how to interview the patients, what are the important questions on medical history, but also on actual complaints, and how to explain, I would say, the good diet for the hormone therapy, which is very similar to what is called the paleolithic type diet. And then there will be a second presentation on physical examination, where we'll see everything about the hair, the face, the neck, all the hormone deficiencies combined, and hormone treatments. And we'll see also in a second module, also for about 2 hours, about the physical signs of hormone deficiency or excess in the chest, the abdomen, the back, the arms, the hands, the thighs, the legs, and the feet. About 18 different hormone deficiencies and hormone treatments. There will be also laboratory tests. What are the best laboratory tests to ask and how to interpret them, and with some examples. And there will be hormone treatments part 1 and hormone treatments part 2, which are very important for us. We will talk about even very far treatments like erythropoietin, calcitonin, vasopressin, MSH, etc. But of course, all the other important hormone therapies. And again, make it simple. And then we'll have a follow-up session, really interesting. Before and after pictures are probably the best part of it. So you really get into your mind how the people have to transform. If you, as a health professional, as a physician, do not transform your patient so that his appearance gets better, that's the mark that things are really getting better inside the body, then something is wrong. So you really need to get into your mind how people transform. And there will be done the practical patient cases. And then there will be an additional frequent questions from answering colleagues session, where how to answer, but this will only be PDF. It won't be video. It's an additional, I would say, a little gift that you could receive, so you know better how to respond to things. And there is also a nutritional therapy session, but this is part of another model. Nutritional therapy have been entirely separated here, or almost entirely. So that is another session, especially for nutritionists, or for those who really want to know everything and know what the diet does and what the nutrients do to improve hormone levels. Well, then they can also interest to those additional ones, which I can tell is fascinating. And let's look at session 1, about when you first come into contact with the patient and you need to screen the medical history and active complaints. And in each of these sessions, I will try to overview something important. There's an appointment, questionnaires, interview, explanation on the diet that will be reviewed. And we'll talk about phone appointments, but also the very important part. You're a physician in 2021, or you're a health professional 2021. You need to be, actually, if possible, have a website where they can book their appointments. And so it's not so difficult. And there are societies that can help you for that, to book your own appointments. Sometimes not always interesting the first time for the first initial consultation, but often the follow-up, certainly it's better. It relieves your secretary from a lot of work. And the time will look, that time that you need to take per patient will be about 1 to 1 hour 30. I work with so many hormones that I need 2 hours, but basically you're not going to do with so many different hormones. I work more than 20 different hormones with patients. You're not, you shouldn't start like this. So 1 or 1 hour and 30 will be normally sufficient to start the first consultation, where you get all the information you need to ask the appropriate test. And so we'll look over in all these factors. We'll try to find signs or symptoms of hormone deficits or excess in the medical history. in the diet, the pollution. And in this consultation, it's also the good time to give advices on what the good diet is, what type of pollution to avoid. Actually, you need to avoid all pollutants, but some are worse than others, and have detox advices. So an example, for example, is depression. Depression is very frequent, and there's a familial predisposition to depression. And we see that if in a parent there's depression, there can be also in children depression, and that can be due to a sort of familial predisposition to hypothyroidism, estradiol and progesterone, testosterone, and growth hormone deficiencies. And so you need to get into mind that it's not just the individual. There's maybe the family. There's some problems. Okay. And so in session 2, that's another presentation. We'll look at physical exam, and specifically the first part, the upper part, and the whole body. And again, we'll look at all these different aspects up to the neck of the person. And for example, we'll look that if you have an adequate cortisol, that is more or less how you look like. But when it gets excessive with cortisol, that's how the transformation is. But we'll see this for many different hormone excesses and deficiencies, the transformation you have. And that puts into your mind what is essential. If the absence of a molecule, or let's say the deficiency in a molecule, gives such a big difference on the body, it should be something important. And that's why everything we do as a physician, if possible, we need to see that it actually improves the hormone levels and not decreases. Many medications that are pharmaceutical drugs actually decrease hormone levels, which is not such a good thing on the long term. And for example, for the hair, diffuse scalp hair loss you have in hypothyroidism, but the hair is also dry and brittle. You see, this can also, the type of hair you can also find in nutritional deficiencies like iron, zinc, B5, B7, of omega-6 polyunsaturated fatty acids. So it's not only one cause. When you treat a patient, think there are several causes giving to the problem. And my strategy, and the one I really recommend you, is to look at all the different possible problems. And if you find several of those, treat them. Treat the hormone and nutritional deficiency, not just one hormone to give, maybe several in smaller doses, probably because you have a synergy between all the products you give, but at least you will have better results. And I can assure you, patient will be happy if you do that, and you are, you know how to do it and do it right. We'll look at what a hormone deficiency is on the face. Is just give an example, like, for example, growth hormone deficiency, there will be deep forehead wrinkles, sagging ears, a droopy nose strip, and a lip thinning. The lips are thinner here, especially at the outer borders. There will be the nasolabial oral folds are actually more prominent, and will be sagging cheeks. So basically, you will have a sort of premature aging of the face due to growth hormone deficiency. And we'll look at many deficiencies, how to do it. But what you need to understand is that a hormone deficiency doesn't only show up in one physical sign. Usually there are several physical signs. And that's what's important of now to retain. And so learn all the different physical signs that a person can have, so you'll be able to know in what intensity, what the degree is of the hormone dysfunction, of the hormone deficiency or excess. And so session 2 is also a physical exam, but then on the lower part of the body, from the chest down to the legs. And you see, for example, this is the body of, let's say, your patient. Will listen how to listen to the heart, so that you can discriminate between hypothyroidism, for example, and cortisol deficiency. There's a difference when you hear the heart. And the blood pressure also can be different. And then we'll look at all different places around the body that you see here, Each one will have several pictures for different hormone deficiencies showing what shows up at that level with a specific hormone deficiency. And keep that in mind. Again, if you have signs on the face, you'll probably have signs on the pelvis or the thighs or the knees, or also on the feet, the shoulders, the upper arms, the elbows, etc. So that you will be able, as a health professional, as a physician, to better treat your patient, because you have this global outlook. You have the global impression of what the patient has. If there are severe signs, physical signs of a hormone deficiency, probably treatment needs to be given at higher doses. Although again, we'll talk that some of the hormone therapies have always to be started at lower doses, or you get into problems. This is the case of thyroid hormones and of growth hormone, for example, but not for other hormones like cortisol or testosterone. It's different. You don't necessarily have to start at the lowest doses with these hormones. We'll also talk about genital examination, breast exam, pelvis, genital tissue, again with pictures, so that you get a good idea of what to do. So, for example, when you have a diastolic hypertension, that means that the lower blood pressure is quite high. That's typical for hypothyroidism, and it's often normalized by thyroid treatment. And we have studies already from very long ago, in 1950, 66, 89, that corroborates that. Growth hormone deficient arm, that's typical norm like this, that is more fatty and with a sagging skin. The sagging skin is very typical for growth hormone deficiency, because growth hormone gives elasticity to the skin. And so if you don't have elasticity, you have what you see here, sagging skin, you must suspect growth hormone deficiency behind that. Hypothyroid hands, usually cold hands that can be swollen, but mainly in the morning, not in the evening, in the morning. And then they can have this more reddish blue color called acrocyanosis, cyanotic outlook of the extremities. Also, the belly here, for example, in growth hormone deficiency, can have a fat, droopy abdomen and droopy, poor elastic muscles, and a skin also that is not ideal, is thin, poorly elastic. So you have skin and muscles become sagging in growth hormone deficiency. Hypothyroid toenails, usually there's not enough blood flow going into the feet, for example, and you will have then white toenails because of this lack of blood flow. So really try as a health professional, as a physician, to get this idea that you can know a lot by opening up your eyes and also even touching and feeling the body of the person. If the feet and the hands feel cold on, maybe there's poor blood circulation due to low thyroid. And you have several of those physical signs of low thyroid, of hypothyroidism, then you are more sure that this patient has hypothyroidism. Also for the breast, the smaller breast can show that there's chronic estrogen deficiency if they're droopy also. A well-sized and good tonic, probably adequate estrogen levels, but if they become too large, maybe there's an estrogen excess, and with progesterone deficiency that facilitates it. So really interesting of being a person like a photographer who really knows what he's seeing, and he can detect based on what he sees the results of hormone deficiencies on the body of his patient. Then there are, of course, laboratory hormone tests, which you need always to do because it always gives additional information, but lab tests on their own are not enough. You need to have the physical examination, you need to screen the patient complaints, and actually when you take everything together, there you really get a good evaluation of the hormone status of the patient. So here we have blood, saliva, and 24-hour urine tests that will be discussed, but always with this practical idea. You need to know what is useful for your practice. You don't need to know all the theory, although some of it is interesting in physiology, so you will get some of that information, but you won't be overwhelmed by that information. You will be probably not overwhelmed, but happily in contact with the information that is necessary, and that I'm trying to give you the big guidelines now, because that's what's to retain from this type of lecture. So we do blood tests, saliva test, 24-hour urine test are the most classical tests. I will mostly focus on blood and 24-hour urine, although saliva has some usefulness. And I will always explain that we give papers to explain how a patient should do a good blood test. And if he's under follow-up, he takes hormone treatments, for example, when is there a change in intake of hormone treatment from the morning to the evening, in order to be sure that the next morning when you do the blood test, you have the adequate levels. So we'll talk about exactly what there is, and you will receive also papers that will help you to help the patient with information, with explanation. So the tests that we do are shown here. There's some more tests that can be done, but these are the major ones. And we check for growth hormone, for thyroid, for the adrenals, for insulin and the glucose and the ovaries and the testicles and things. And we'll explain also why these tests, what is in here in red globally, are the most important tests to do. And we'll try to give you also an idea of what the optimal levels are for a patient. It may depend also on his body size, so and his muscular structure. And then we'll talk about some of the tests in details. And here, what is in yellow is what is more important. But I don't want you to retain all the details here. What I want you to know is that there are some tests that will help you better than other tests. And we'll discuss why, and we'll show how to work with it, how to interpret the results compared to not only reference range, but optimal ranges within the reference range. So this will be an important part, that this is a capacity, a skill that you have to learn, how to interpret hormone lab tests, because it's not so simple that below the lower reference limit of the reference, everything's bad, and within the reference range, everything's good. No, there's a gradation within the reference range where levels begin to become too low for hormones. We'll also talk about the high frequency of hormone deficiencies. And you know, those who have already followed, that there's probably a very high frequency. Let's face the facts. Do you believe that there's one baby born in this world with pollutions? On average, there's about 6,000 pollutants in the fat of most babies. That there's one baby who's born with optimal hormone levels? No, even babies start having hormone deficiencies. Of course, you can correct a lot there by adequate food without pesticides and things like that, by having the mother in the pregnancy eating, but still, it is almost impossible of the 35 important hormones to have optimal levels in those levels, even if there's no pollution at birth. Makes you think that at adult age, when there's a wear and tear process, there's more deficiencies possible. So it just shows you that it's really important to be able to detect even smaller degrees of hormone deficiencies, because it will help the patient a lot. And then we'll talk about hormone therapies, and then in part 1 and part 2, again, two times 2-hour lectures. And we'll talk about this, of course, overwhelming scientific evidence supporting hormone therapies, much more than for pharmaceutical drugs, and outclasses. And then I hear people saying, no, but the compounded hormone therapies that are often promoted in this domain have no science behind them. Completely untrue. When you check all the hormone therapy, double-blind, placebo-controlled studies, they're mostly done with compounded hormone therapies, especially compounded for the scientific study. So we really have a lot of hormone treatments that have a strong support in comparison to the lower support of many pharmaceutical drugs. And I'm not against pharmaceutical drugs. I think everything has a place. I just want to promote the place of the bioidentical hormone therapies on which I will talk most of it. And here's the real thing here. When you have hypothyroidism, for example, you have a lot of complex. There's usually a tendency to weight gain. There's usually a tiredness, more important in the morning. There's also easy depression. There's pain in the body because of mixed edema piling up. There's dry and flaky skin. There's poor concentration, etc. And it can even be high blood pressure and high cholesterol levels. So a lot of complaints, okay? And pharmaceutical drugs will usually just treat one of those symptoms because they treat the consequences. And so we have weight loss programs, coffee that will be given to these people, antidepressants, each time for one complaint, anti-inflammatory and anti-pain drugs, vitro fertilization for decreased fertility, skin creams, statins, ginkgo biloba, etc. Okay, so you imagine this patient has to come with a whole bag of medications, pharmaceutical medications, and then a series of therapy, and probably has also to go to a psychologist. But when you give thyroid hormone supplementation for hypothyroidism, one therapy treats all. Just one little pill in the morning. And the patient will feel better than was all this combination of drugs and therapies that may have side effects. So there can be in hormone therapies also lots different things that to be applied. So we'll look at tips, practical tips, and I'll really give a good idea is that first look at the hormone deficiency before you start giving a pharmaceutical drug, because if a patient has a recurrent or chronic symptom, it's often due to hormone deficiency. But one thing I will say is that all the treatments seem to work better if the diet is paleo, is fruit and vegetables, organic preferably, and meat and fish cooked at low temperature and not in oil. And so there are first-line hormone treatments among the sex hormones and the thyroid, the growth hormone, the melatonin, and the adrenal hormones. And then there are second-line hormone treatments that is not often talked, but for many patients will make the difference, will really get what you can call an optimal health. It can be oxytocin, IGF-1, ACTH, thymosin alpha-1. So we'll look at all these different treatments so that if you need, you'll probably be able to treat these deficiencies. At least you have a beginning of the doses to apply. And for example, oxytocin in sublingual, usually not more than 5 to 10 international units because it's quite efficient sublingual. It's my preferred mode of administration of oxytocin. I can tell you, I took some oxytocin just before this lecture, extra. So, so it makes me in a better mood. And intranasal spray, which is what you can find in pharmacy easier. Often you need more than 2 sprays a day to really have efficacy. And then you have the intravenous or subcutaneous forms that are usually used in hospitals for delivery or etc. That's often can be higher doses, up to 2 times 10 international units a day eventually. So we'll talk about those practical things. I want to give you a little practical suggestion if you have a jet lag. If you have a jet lag, you know melatonin can help. But how do you do it exactly? If you go, for example, from Europe to the States or from the States to, usually go from the States over to Europe then to Asia. So if you go from Europe or the States to Asia, there's a difference. So let's look at westwards. In westwards, you know that the daylight comes here and the night follows. So basically what you have when you go west is that the night comes later. The travel day is longer, 3, 6, maybe 9 hours longer. So that when you arrive, there's often still daylight there. And you should take melatonin once arrived at destination at bedtime, not several days before at the same time. No, you take melatonin when you arrive, but you do need to increase the dose then. And we'll talk about how much the dose you should increase. So those practical tips are important to give to the patient too. So you will get this information. So session follow-up, session, that's really interesting session. We'll talk how to do a follow-up with a questionnaire. You will be, those who subscribe will get this type of questionnaire that they may use with copyright restrictions. And there's also additional questions, and it's not all the questions are there on the paper. If the patient has a special problem, you know well that you probably need to give additional questions. But what's really interesting in here is that we're getting many pictures that really put into your mind how the body transforms with a hormone treatment. For example, thyroid, this you know probably from school, that from overweight you get to thinner easier. So that's good. Okay, but we'll see this for on the face. We'll see that for the nose, the changes on the nose, on the cheeks, on the eyes, on the feet, the knees, and things like that. So you really get into your brain this idea: what is before and what is after a treatment, and where should I strive for without getting into the overdoses, because we'll talk about also how it looks like with the overdose. So keep in mind that with hormone treatments, you get something fantastic, is that you can see the changes with your eyes for most hormone treatments. If you don't, something's probably wrong with the treatment. We'll have a patient case session in this, and then an additional session where we'll talk about frequent questions from patients and colleagues. And I'll just give you a little overview of that. Is that how quick do improvements come with each hormone treatment? That's a question you need to know. And that is different for thyroid hormones. It's mostly the second month that the improvements come, and then the third month it's better, and fourth month is better. And some other treatments go quick, like cortisol, almost immediately. And we'll have also questions like, does it treatment suppress the endocrine gland? Am I damaging something by taking the hormone treatments, or does it cause cancer? So we'll talk that into details, but it's a PDF that you need to drink that is not really part of the formation. It's an additional, gives you information. When people say, why do you give me so much hormone and nutritional supplements? How to answer that will be, why is treatment expensive or not expensive, and how to motivate patients to change their diet, all those legal things, and also legal information. So this is really important, but has not priority, and we're not giving this as a video session. So model 2 is, this is, I would say, what changed my life the most, I think, at least in the beginning of my career, is I had adrenal deficiency, but didn't treat it well before really being a doctor. And so adrenal hormone therapists will talk about cortisol deficiency and diagnosis and treatment. We'll talk about cortisol treatment problems. We'll talk about DHEA deficiency, diagnosis and treatment, and then DHEA treatment problems, and then what to do in beneficial effects in disease. It's really a lot of information that you need to know in that disease. Do I need to give a higher dose or not? So that sort of answer you will have. And we'll also talk about the importance that if ever you give cortisol, always to give DHEA as a protection. Aldosterone and pregnenolone therapies, other adrenal hormones that may be of importance, and then patient cases. Of this, we'll also have a nutritional, dietary, and lifestyle therapies that increase cortisol and DHEAs, but that's a separate formation, cycle 2 of nutritional therapies. And then we have this cortisol deficiency with all the different details of a consultation only for cortisol. And what is important is, if you're against cortisol, you're probably against the most essential molecule in the body, not only to stay alive, but for your quality of life. So don't be against. Just know how to treat it safely. And so we have cortisol deficiency. If you have too little, you have distress. Your life is miserable. You suffer more than other people because everything inflames, and your patients too. So the patient needs cortisol. It's not a question of, I don't want to take it. It's a question of, how do I take it safely so I feel good and have no side effects? Cortisol is also essential to stay alive because the total disappearance of cortisol gives a death within 24 hours. And how? Well, there's a collapse of the blood pressure and a collapse of the sugar level, a severe hypoglycemia, a severe arterial hypotension. You don't have enough blood circulating in your body, no blood pressure, you die if it's so low. So an example, for example, patients with acute myocardial infarction, you get a heart attack, okay? And then you follow up within 30 days. Those who actually survive have a better cortisol level. It's still low compared to the others, but it's better because those who are in the 25% lowest values, the bottom quartile, that's 41 microgram per deciliter. The average level is 160, 150, 170, depending on the labs. And you have 9 times more risk of dying within 30 days after acute myocardial infarction if you have a level in the 3 upper quartiles. So the patients who died within 30 days had a serum cortisol that was only 14% lower than those who survived. But that 14% is the whole difference. The levels are already low in acute myocardial infarction, and if they're even lower than the average, it's not good. You die easier. So a little deficiency compared to the others makes the whole difference. You have to have absolutely, let's say, more than 50 micrograms per deciliter of serum cortisol to survive. So we'll look at this and we'll have the same sort of overview. We'll start with medical history, then we'll actual complaints, physical exam, and lab test, and then tell what to give as supplementation. And I will talk also about other hormone supplements that can improve cortisol levels. And here among the physical signs you have of cortisol deficiency is brownish tint and dark circles. Because when you have low cortisol, the pituitary hormone that stimulates the adrenals to secrete more cortisol is more secreted, ACTH, and that gives irregular darkening of the body. So you get irregular brown pigment spots and the dark circles around the eyes. So also when you have cortisol deficiency, what really is different from cortisol deficiency and the others is not the fatigue, because fatigue you find also in other deficiencies, but it's this suffering process. There's an intense psycho-emotional suffering. They suffer more than other people, much more. Their whole body is inflamed and their brain is inflamed, so they suffer more. Remember that. Cortisol is really important and you need to be able to treat that. And there are also ways where you can do it indirectly by improving food and things like that. The first thing is to stop sugar, for example. We'll see that in nutritional therapy session. So cortisol lab test, blood, saliva is important here, and 24-hour urine. So you have several treatments. You can have the bioidentical hydrocortisone, which is also given on a higher dose in men more than women. The dose is higher because men have more cortisol production. Prednisolone, that's a synthetic derivative that is quite good. And methylprednisolone, that is to give in certain conditions that we'll talk about exactly. The doses that you have here are physiological doses, maintenance doses. Again, the tip here, and I'll repeat, always combine with DHEA when you give cortisol, because it protects you against excessive catabolic effects. That's what you need to remember here. And there's when you take the bioidentical cortisol, which is called hydrocortisone in pharmacy, 10 milligrams of hydrocortisone is equal to 10 milligrams of DHEA. For synthetic derivatives, they are more powerful. So smaller amounts of synthetic derivatives are equal to 20 milligrams of DHEA here, for example, 5 milligrams. So very important to give DHEA to protect against bad effects of cortisol. And then we have the cortisol treatments problems, how to solve cortisol treatment problems, how to give cortisol diseases so that it works well without side effects. So an example here, and because I show also some studies here and there to show the science behind it. This cortisol deficiency, you have this type of eyes, for example, but they're also the eyes are inflamed due to low cortisol, but also due to the fact that the eyes are dry. And then you see that the tongue is dry. And in Sjogren's syndrome, where you have those physical signs, you see that when you give prednisolone, for example, you can double to 3 times have a higher amount of saliva production when you treat the inflammation that is behind there with a glucocorticoid. Also in ulcerative colitis, when you give prednisolone, for example, you have decreased abdominal pain, and you get all the scores are better and less blood in the stool. So it's really a treatment that works. There's science behind it, but what is forgotten in most of the studies, I would say almost all, 99.9%, is that you may not give prednisolone, you may not give methylprednisolone without DHEA as a protector. So DHEA deficiency, that is not only the protector of cortisol, but also has some specific effects for the immune system, for example. In women aged 18 to 25, and that's also in young men the case, there's a lot of DHEA, so the overwhelming amount compared to other hormones. And DHEA sulfate, under that form, there's 12 more in milligrams than IGF-1 in the blood. And there's 35 more than in cortisol, and 30,000 times more than T4, because the binding to sulfate makes it long standing in blood. And so this is the pressure you have. So DHEA is the most abundant hormone in the blood, and is also, after cortisol, most produced hormone in milligrams per day during life. It's less produced in older age than cortisol in milligrams. That's why cortisol is more produced, actually, but it's the most abundant hormone you find in blood. In an 80-year-old woman, you see there's almost no hormones left, not much, and DHEA sulfate levels can be up to 10 times less than a younger woman. So knowing that, you can say there's no older adult without DHEA deficiency. And if you don't treat yourself and you're above, let's say, age 30, 35, 40, you're probably harming a bit your body by this negligence. You're neglecting yourself of not treating the deficiency and doing that the same in the patients. You see, atheroma plaques also in older adults will make also that even if you have a lot of DHEA, it doesn't always go inside of the organs easy because the blood flow is not so good because of atherosclerosis. So we'll see the same sort of overview of the presentation, where we'll see all what you need to know to be able to diagnose DHEA deficiency and to treat adequately. And you also know something about what other hormone supplements can do to the DHEA levels, how they can, many of them can improve it. So again, I want to give you a good tip. When you are planning to treat your patient with DHEA, look at the armpits. You can also look at the pubic area. If there's not an abundant enough body hair there, like here, there's poor body hair, then you have actually DHEA deficiency. And because the armpit hair is very dependent on DHEA levels. So here we have a blood level of DHEA sulfate, and you have a lower limit and an upper limit. And what we see is that below the lower limit, of younger adults, because in old adults, the lower limit is more, you can, below there, in these levels, you can already have increased mortality in men with chronic heart failure. And DHEA below 1,000, which is still below the lower limit of young people, but well within the preference range of young, older, you have lipid problems and more fat mass. You have also more cardiovascular mortality above this value. And then you have inverse association, meaning that the lower the DHEA levels are, the more you have these diseases. But so that starts from a high. So that what that means is that within the reference range here in yellow, this part, those levels, if you're in the lower half of the reference range with DHEA of young adults, you already have increased risk of disease, even of aggressive prostate cancer in men, for example. So you need, what is good is to be where it's green. In that zone, you have the best optimal levels where you have normally no risk of increased risk of disease. So we'll talk about also how many placebo-controlled trials you find with DHEA treatment, etc. And then we have the doses that we'll give, like here. What you need to know about all doses is that women are more sensitive to DHEA, so they need a lower dose. But also some women need a very low dose because otherwise they develop acne or scalp hair loss. That problem you don't have with men. So you need to know this and to be careful with DHEA in women, but provide DHEA when it's necessary, but without it giving side effects. Also interesting to know is that DHEA in men at high doses, for example, does not 50 to 100 milligrams, does not really change a lot testosterone levels or dihydrotestosterone, the main male hormones. But the metabolite of dihydrotestosterone that reflects masculinization, that the reflex is really dihydrotestosterone is efficient, that gets higher with DHEA. So at 50 milligrams here and 100 milligrams there. So it means that in the cells, DHEA really can become an androgen and work as be converted to dihydrotestosterone. DHEA treatment problems, we'll have a whole session about that, and we'll talk about the acne, which is a bigger problem. That has solutions. Also, we'll give some studies showing that DHEA treatment is efficient to treat major depression, but you need to give higher amounts of DHEA often to get that sort of effect. DHEA is not so efficient on depression as testosterone. So we'll talk a bit about that. And then erectile dysfunction, low levels are found in Korean men here. And when you give DHEA, a placebo does not give much effect on men with erectile dysfunction, but when you give DHEA, very slowly, it takes up to 24 weeks to get all the effects of DHEA. So this is really a slow hormone, but maybe very efficient for erectile dysfunction. So we'll talk about also other adrenal hormone therapies like adrenal aldosterone and pregnenolone therapies. And what is important to know is that aldosterone permits to have a clear vision. It's not just a hormone for blood pressure. It's one that you have not an empty head, you have a clear head. You pay easily attention if you have enough. So it's not a bad hormone that gives hypertension. If you have just the right amount, it makes you better concentrate, better attention, and you feel good in your head. And when you stand up in the same position for more than 10 minutes, there's no difference. You feel good when you have enough aldosterone. And then we'll see what happens when there's a deficiency and what the diet influences and lab tests, and how to give fluorocortisone with synthetic aldosterone and avoid overdose. But what you see here, this is a person looking vaguely, like in a fog. And this is typical for aldosterone deficiency, a foggy, absent-minded look. You can see that in the consultation when you look at the patient. So remember, people who have that need aldosterone or its synthetic derivative fluorocortisone. If I didn't take fluorocortisone, and I took a little additional dose now, I would be foggy and I wouldn't be able to concentrate well and to be there with you. So aldosterone deficiency, you need to lay down because you feel better in the head. Laying down, the blood flow is better. That's really how you can recognize easy aldosterone deficient people. Also, aldosterone can give severe hearing loss. A study shows that people with severe hearing loss have, on the average, 50% lower serum aldosterone. And by providing aldosterone, bioidentical aldosterone, you reverse the hearing loss in this sort of typical old age hearing loss. Pregnenolone therapy is necessary for the memory. We'll also have all the data that is necessary. Just to tell you that in the brain, there are high levels of pregnenolone. And also in amygdala, in the hypothalamus, the brain is over producing locally pregnenolone. Hippocampus for the memory. There's 25 to 35 times higher concentration in brain than in blood. Because look at the blood, the concentrates is on the average about a little more than 100 nanograms per milliliter, but here you have 4,000, there are 3,000. So it must be important for the brain, and indeed it improves short-term memory loss. And here in patients with schizophrenia, pregnenolone was given 50 milligrams a day, given in the morning. It doesn't work in the evening. That's again a tip. Try to remember that. If you ever take pregnenolone, always in the morning. If you take it at nighttime, it won't improve your memory because you don't need a memory there, but it will make you a little more awake. So it's better in the morning. So it decreases, it improves visual attention and sustained attention, and you can execute functions better. Spatial working memory was also better. So it really improves. We have the proofs of that. And we also have a patient case session, patients treated with these adrenal hormones. Now let's look at model 3, which is the model on growth hormone and IGF-1 therapies. And we have, again here, 2-hour presentation on growth hormone deficiency and diagnosis, the growth hormone treatment, but also use of growth hormone fragments, IGF-1 deficiency and diagnosis, and IGF-1 treatment with also long-acting IGF-1 and muscular growth factor treatments and IGF-1 treatment problems. So we really get in depth as you probably never will have seen ever before. But again, what is important here is not what is in the training program, is how you can see what is essential for your patient. And these are really essential treatments that can change a person a lot. We'll also treat about growth hormone treatment problems and disease and how to treat overdose. And we'll have patient cases who are treated with growth hormone IGF-1. Now, we'll also have an additional PDF for IGF-1 and growth hormone controversies. Let's say it's well explained, you can well answer to people who think, growth hormone is that dangerous, or IGF-1 for cancer, or whatever, of diabetes. Well, here you get your answers with the scientific studies. And then we'll also have in the nutritional cycle about what lifestyle, dietary improvements and nutritional therapies can do to improve growth hormone, IGF-1 levels and activity, with a special focus on what is called the growth hormone secretagogues, the compounds that can stimulate your secretion of growth hormone. It's not enough to totally treat severe growth hormone deficiency, but it can help in younger people. So we'll talk about why it may not be so adequate in older people. It's not bad for growth hormone secretagogues are not bad for older people, but it's not very efficient. And so let's look at the first session here on diagnosis, and we'll show a bit how the change can come in a person who's obese since 18 years with 2 years of growth hormone treatment. That person had a growth hormone deficiency. That's why it works so well with growth hormone treatment to get this more beautiful body. So we'll have here again sessions on all the different aspects that are necessary to come to good diagnosis of growth hormone deficiency. And we'll talk about a lot about psychological symptoms that people have when they're growth hormone deficient. And among those, that's a study I published, anxiety, dramatizing, excessive emotions in the majority, sharp verbal retorts. These symptoms have been based on the typical description of what happens psychologically in children with growth hormone deficiency. And I just had a questionnaire where I presented to older adults and before they were treated, and we saw then that was much improved with the treatment. These are real things that happen. You're much more anxious when you're growth hormone deficient and you dramatize things. And here you have also physical signs that the thin skin is very important. The growth hormone thickens all things. The thin skin is very typical. And also this loose back muscles in draperies is typical for growth hormone deficiency. In the lab test, we'll see that you really need to check IGF-1 and its protein that transports it in the blood the most, IGF-PP3. And the ratio behind, you need to have a high IGF-1, IGF-PP ratio to be sure there's enough of IGF-1 getting in cells. IGF-1 is a hormone that is actually produced mainly due to the presence of growth hormone. So if there's almost no growth hormone, there's almost no IGF-1. And it's a more stable value. And growth hormone is only secreted at night a lot, 3 first hours. And so it's not at night that you do blood test, you do it in the morning, then check IGF-1. You have an idea of the growth hormone activity. So we have done the treatment, what to use, and subcutaneous injections. And interesting, and I want again to give you a tip, you don't need always to give a high dose of growth hormone. Most of the time, it's smaller dose I give to my patients with great efficacy. And this is a study that explains why. Is in fact that if you give a low dose like 0.1 milligram per day of growth hormone, the physiological production a man makes or a woman makes is 0.35 milligrams. So you give a fraction of that. Well, basically, during the treatment, you do decrease on the long term, at least, the sugar levels. But at month 18, if you stop for 6 months, you still keep an improvement. The sugar levels are lower and insulin levels also lower, and insulin works better. While if you give a higher amount, you actually create a sort of sugar level does not really decrease, insulin 70, but the body composition is better. There's less fat, more muscles. But if you stop, everything reverts back to baseline. You've lost the benefit. While there's a persisting benefit if you give a lower dose. So low dose is really good. And why it is so, we'll talk about that in the presentation. DHEA supplement is also a way you can increase IGF-1 levels. When you give that, especially in women, even more than men, 50 milligrams, you get a 10 to 20% increase of serum IGF-1 levels. Interesting. And we'll talk about also growth hormone fragment, which is a fragment of growth hormone that's specifically designed actually to have decreased obesity. It's called advanced obesity drug. And it really can decrease the fat in the abdomen. So this is the type of result you have with ODA if you give high enough doses to obtain that. And it has the advantage that it doesn't increase the sugar level, which growth hormone can do during the first 3 or 6 months of treatment. After that, not. So if you have access to it, because it's not easy to get access to it, at least in pharmacies, because it's widely sold, but without any control on internet websites. So IGF-1 diagnosis, basically a bit like for the growth hormone and other hormones, will overview all different aspects necessary for diagnosis and just show you that thin lips and atrophic jaw bones are typical for IGF-1 deficiency. Everything atrophies, all organs atrophy more due to low IGF-1. Insulin-like growth factor 1. And then we'll talk about treatment problems and things like that, and other treatments that can be given with IGF-1. So session 4, we'll see what the beneficial effects of these two therapies, growth hormone and IGF-1, is on disease. And again, I want to show you what you need is to use your eyes. Your eyes is a camera that will give you very good information directly. You look before, this is growth hormone deficiencies and with all the symptoms. And this is after 2 months of growth hormone and 4 months of testosterone. It's mainly after 2 months of growth hormone. Look to change, how the face is stronger. And then their swollen feet is usually the first sign of growth hormone excess. That's really too many. It's not just a nose that would be bigger or hands. No, the feet swell up. That's the alarm sign, a reversible arm sign. And we'll have patient cases. We'll have this additional presentation on controversies. And just to show you, for example, people think that growth hormone could give cancer. Actually, growth hormone decreases most cancers when you look at the study. So it's the opposite. And in middle-aged and older men, what is the risk of glioma? Okay. Well, if these middle-aged and older men have high levels of IGF-1 just in the upper 66 or 67%, not the lower 33, well, they have minus 70% lower glioma risk against those who are in the lowest tertile. So low normal IGF-1, if you're 40, 50, 60 years of age, is not good because it can increase your risk of glioma. And you know that the risk of glioma increases by the cell phone use. Not after 2 years, after 10 years of use. And now let's look at psychological disorders and hormone therapies. We'll see about anxiety, depression. They were quite extensive, about 4 hours on depression. And then lower stress resistance, irritability, and then autism and schizophrenia. So we'll see, let's say, most problems that physicians and psychiatrists can encounter psychologically with the patient. And we'll have then patient cases. And in the nutritional cycle, cycle 2, we'll see how with a better lifestyle, a better diet and nutrition, you can decrease anxiety and depression. And we'll see also in the second session about stress, autism, and schizophrenia. So we'll really have some practical information for nutritionists. And let's look at anxiety and hormone treatment. When you look at a person who's calm like this, that's typical what it happens with a lot of growth hormone. This patient has a lot of growth because you see that the jawbones are big, the nose is relatively big, and the forehead is large, and the hair is quite thick, signs of a lot of growth hormone. So growth hormone therapy has really a peace-giving effect, strong anxiolytic effect, really decreases anxiety. Amazing. And when we look at a study of growth hormone deficient adults who have had that because of a brain injury, traumatic brain injury, they have in general, they're always anxious and they always have a problem on the body, somatization. And when you give 6 months of growth hormone treatment, you significantly improve. You get this sort of calmness, the frequent worrying, the phobias, dermatization, gone. The excess sensitivity for interpersonal relationships, the paranoid thinking, gone with 6 months of growth hormone treatment. And when you get the same patients, you stop the treatments in 3 of those patients. 12 months after stopping the growth hormone therapy, they become anxious again. And you get these worrying, frequent worrying, phobias, traumatization, excess sensitivity for interpersonal relations, paranoid thinking. Do you really want to live on if you have a growth hormone deficit, to continue living with your growth hormone and be anxious all the time and dramatize and make a fuss of a small thing? No, take growth hormone, but take it safely. The right dose for you and for your patient, not excessive doses. So for depression, we see that, for example, in euthyroid patients with normal thyroid function, so-called, 18% have depression, 56% have depression if they are hypothyroid, young at least, but if they're older, 75% of patients have episodes of major depression. So hypothyroidism spoils your life. That's what you need to remember here. It makes you see the bad side of life while you're there to see the good side of life in your patients too. And you are, as a therapist, the magician can change the situation from negative to positive. So there's 3 to 4 times easier depression in hypothyroidism. And in postmenopause, this is a study, actually what it showed is that women were put in the postmenopause on estrogen therapy, transdermal, a patch, all had no depression. But as soon as you stop the patches, after 3 weeks, you had actually much more depression, whatever the scale is searched. So basically, these patients were women who, before having female hormone treatment, had a tendency to do postmenopausal depression, but it disappeared with treatment. And when treatment was again interrupted, it appeared again. So estrogen deficiency gives more depressive symptoms, 2 to 3.5 times easier depression. That's what you need to remember. Hypothyroidism, 4 times more depression, 3 times more depression with hypoestrogenism. And then other hormone treatments like DHEA, for example, shows that DHEA, if you give it after 3 weeks at 90 milligrams, not the 20 milligrams, 90 milligrams, you get significant improvement of what is called the midlife dysthymia or depression. 60% of patients improved here compared to 20% with placebo. And especially the lack of feelings, the loss of energy was improved, lack of motivation, this emotional neutralness or numbness, sadness, worrying were all improved, these patients. But we'll look at in more details. I'm going a little quicker here just to give you the basic ideas that when a person is depressed since a certain time, you probably have a hormone deficiencies. And it may be DHEA, maybe growth hormone, it may be thyroid, or maybe estrogens or other hormones, but you need to treat what is deficient. So if there are 2 or 3 hormones deficient, treat the 3, and that will be more efficient than giving an antidepressant. I'm not against antidepressants. They may have a place, but transient, not for long-term. Long-term is more hormone treatment. Now, what about irritability and low stress resistance? What can hormone therapies do? Well, there are therapies like melatonin, for example, and when you look at this study, melatonin can actually be increased by meditation. So you can have some ways to improve hormone therapies different than just giving the hormone. But those who are relaxed usually have more melatonin, except when they concentrate, then it takes the melatonin away. So for example, here in this study, advanced meditators have higher melatonin levels, that is about 44% higher. So they have melatonin that calms them down all the time. But when they meditate, they concentrate on something, they lower the melatonin more. It decreased by 39%, becomes as in other people. So it's not a handicap having a lot of melatonin. And to show you that people with paranoia, actually, when you see here, they have a lack of ACTH in growth hormone secretion, so they have adrenal and growth hormone deficiencies easier, and that makes them more paranoid. We'll explain why, how, and things like that. But it's important to know because then you have treatments. You can correct the situation good. In autism, people say there's no solution. We'll see that there are solutions. There are solutions because in autism, there's not only lower levels of oxytocin in blood, but they have more inefficient oxytocin peptides, oxytocin linked to an amino acid. And that ratio is higher. And they also, we will see in other studies that they have low receptors for oxytocin. So autistic boys need oxytocin to get out of the autism. And that's also the case for autistic girls. And when you look at schizophrenia, you look at, well, you see that they're not warm-hearted. So that is typical for low DHEA. They're tense, not relaxed. It can also lead to low DHEA and dry eyes, low DHEA. So basically, when you look at psychiatric patients and schizophrenic patients, you can see hormone deficiency on them. But then you have also, by looking at your patient that has psychological problem, you know what to do. And when you do that, you will decrease the psychological disorder. In some cases, you will cure it. So here's a study showing that it's in a meta-analysis. It showed that DHEA therapy actually decreases negative symptoms and decreases extrapyramidal symptoms. You know, when you take antipsychotic drugs, and all these patients who take antipsychotic drugs, they had less side effects of those antipsychotic drugs, less trembling and abnormal movements when they took DHEA in conjunction with the antipsychotic drugs. We'll also have patient case session, and then we'll have this fascinating session on longevity. Can we extend with hormone and other therapies longevity? And we'll have a lot of different sessions, and we'll have one on centenarians, all you ever want to know about centenarians. And you will also have my best lecture, Positive Psychological Attitude Centenarians. It's maybe even better than a hormone lecture. You will like it. At least I like doing it. So I'm sorry of maybe not being humble, but at least I think it's not all hormone treatments. Sometimes you need to make a decision to have positive psychological attitudes. And centenarians, for whom I have a lot of admiration, have often made those decisions of being positive in their life. And we'll explain that with very many aspects. And so then we'll have the link between hormone therapies and longevity, 4 hours of lecture. And then we'll have many lectures for nutritional therapies on lifestyle habits, psychological attitudes that improve longevity, dietary diets that improve longevity, and then also nutrients that improve longevity, and then what pollutants do, what pharmaceutical drugs can do. And we'll also have a nutritional cycle. Everything that is in green is for the nutritional cycle. Also, the same lecture on centenarians, on their positive psychological attitudes and the micronutrient and hormone statuses. Now, centenarian facts, just to show you that in Gorgias was a philosopher, a sophist, was 483 before Jesus Christ born, and he apparently lived up to 105, 109 years. So centenarians were existing in that time also. And so that makes it that we haven't done so much more for life extensions in all those years, because that's more than 2,500 years ago that he was born and lived long. And there are others who also apparently attained 100 or very close to 100. So centenarians, what they have, one of the 25 different qualities that they have compared to other people is that they adapt to changes. And it's a way that they can cope with adversity. What they do is they don't stay on their ass and say, terrible what happened to me and I cannot do anything anymore, I'm paralyzed. No, they say, what can I do to overcome that thing? They overcome all sorts of challenges. They even overcome the death of their spouse, but also the death of their children often. And they make new friends, new relationships, so they can adapt to losses, physical, and even if they have a leg that works less, then they'll try to work better with the other leg and have something to help them walk. That's really the adapt. And we'll also see about the micronutrient status and the hormone status of these centenarians. It was good lectures that will give a lot of, will trigger your curiosity. And for example, they have higher levels of red blood cell magnesium, healthy centenarians, and lower levels of calcium. And healthy centenarians also have less risk of insulin resistance. They usually are thinner, they're not usually not fat. So we'll look at the hormone therapies and longevity, and we'll look even on premature aging disease. And we look at those premature aging disease, what they show actually hormone deficiency signs. And for example, the Werner syndrome, which is adults that suddenly start premature aging and die around age 50 or 45, they have almost no growth hormone secretion, very, very low growth hormone. And you can improve the growth hormone levels in IGF-1 with single daily growth hormone treat. So one of the treatments of those patients is to provide them with growth hormone. And we see that mortality actually in growth hormone deficient patients is very high, almost 4 times as high as a normal population. But on the other hand, if you give long-term growth hormone treatment, you decrease the mortality by 78%, meaning that you, in place of seeing them die 15 to 20 years earlier, they actually have a normal lifespan. So try to start treating your patients with severe growth hormone deficiency at least soon. That will help them live a longer life. And so hormone therapy, breast cancer, we see that estrogen therapy decreases the risk of breast cancer mortality by 41%. If it's given in women who had natural menopause before age 40. And when you look here at studies in women who had breast cancer, that's a typical sign of breast cancer, campaigns against breast cancer. Women who received after breast cancer hormone replacement therapy had 50% less breast cancer recurrence, but also decreased their mortality rate, breast cancer even more, 66% lower. This corresponds to something like 7-8 years longer life. So we should start to treat all our breast cancer patients early enough. Total mortality was decreased also by 52% in this study, and there are many more studies. DHEA also, it's interesting that women with low levels of DHEA sulfate, for example, have the highest mortality, that's surviving curve, so they don't survive easy. We'll also give specific tips on how to adjust hormone therapy to older patients because it's not the same for older adults. You might have to give lower doses or different doses at least to these patients compared to younger adults. So we'll see all the different cases. And then let's look at the cardio and cerebrovascular diseases and the hormone therapies for that. This is really an exciting model because we'll look at all the things that you can do as a healer. Don't forget that you are a healer, you who are listening. Even if you're a patient, you're the healer for yourself, the best one even. You need to get informed. And here you get strong information about, if you take all those cardio and cerebrovascular disease, they make most of the mortality of people, the majority. And so we'll see how to improve lipids with hormone treatments, atherosclerosis, arterial hypertension, thrombosis, hemorrhagia, and other bleeding disorders, coronary artery disease, cardiac arrhythmia and heart failure, and stroke. Really exciting. And patient cases, we'll have them also, patients who have those type of diseases but are treated with hormone treatments successfully. So that's for the hormone therapy cycle. And then we have some information for nutritionists, like nutritional therapies to improve the lipids, the peripheral artery disease, the arterial hypertension, nutritional therapies for coronary heart disease, nutritional therapies for stroke. So really get, I would say, efficient information, how to do it also with nutritional therapies. And of course, the good healer does everything. Everything that for that patient is necessary. So you still need to have lab tests, to do physical exam to see what are the most important hormone and nutritional therapies to be able to do everything. So let's look at what lipids does. So basically we'll see in this lecture not all forms of dyslipidemia, increased levels of total total cholesterol and LDL cholesterol, Reduced levels of HDL cholesterol is also not good. High levels of lipoprotein A. What you can do is hormone treatments to improve that. How to counter higher levels of homocysteine or high levels of triglycerides, also high levels of antibody against oxidized LDL cholesterol. We have already the information. And you will see that with statins, it's maybe not so necessary, or it's a last resort treatment. Because with hormone therapies, you not only improve the lipids, but you improve the heart, you decrease the risk of stroke, and many other diseases are decreased. And actually, you know what? What you cannot say with statins is the patient feels better, feels more energy, better mood. So let's look at what thyroid treatment can do, and thyroxine, which is not the most potent one for the lipids, but here in the study, it decreases compared to initial status, the cholesterol, total, LDL cholesterol, and apoprotein A and B's, and also decrease the lipoprotein A. In conventional medicine, which is actually more pharmaceutical drug medicine, it said you cannot do much for lipoprotein. Yes, you can, but you need to treat the hormone deficiencies to do that. And testosterone can also decrease the lipoprotein by 25 to 37% here. So we'll give that in detail. I'm overviewing here. I just want you to remember that there's a treatment for lipoprotein A. There's thyroid, there's testosterone, there's growth hormone, and there are other treatments that can help, and we'll see that in detail in the lecture. Atherosclerosis, interesting is that it's reversible. I don't mean all atherosclerosis is reversed, but much of it is. Look here, total reversal of premature atherosclerosis with growth hormone therapy. These are controls, healthy controls, no problem with atherosclerosis. This is what growth hormone deficient men have. 30% thicker intima media thickness of the common carotid artery. And when you give growth hormone treatment within 6 months at a dose of a little more than 1 unit a day, which is about 0.33 or 35 milligrams per day of growth hormone, so a physiological dose, you completely normalize the intima media thickness of the common carotid arteries. This represents what happens in the body. So you, all over the body, you reverse totally the atherosclerosis. Arterial hypertension. What we see when we look at blood levels, this is the lower level of TSH, it's the higher level, and this is the average level. Well, when you have a level of 2.1 or above, you have normally, you're starting to be hypothyroid. Well, you have 40% higher risk of hypertension. And here are studies that above 2, you actually have more atherosclerosis and more systolic blood pressure, higher and higher diastolic blood pressure. There are many studies showing that. And also you have studies that when it's above 1.3, you have a higher risk of systolic and diastolic hypertension. That means that even if your TSH is within the reference range, if you're not below the average TSH of a population, you have a higher risk of arterial hypertension. This should be the optimal levels TSH, not just within reference range. It's the whole. It's actually lower levels that are good in TSH and high levels of thyroid hormones that are good. We'll see that. Now, what about coagulation problems? Well, interesting is the melatonin treatment decreases at night the possibility of coagulation of making blood clots at night. And look at it inhibits platelet aggregation, and a maximum is about 130 in the night. Now, did you know that it's 1,000 times more potent than aspirin? So why are we giving to all those cardiac patients aspirin while we have melatonin? Melatonin at the dose of 0.05 milligrams, for example, sublingual, is more potent than the 80 milligrams of aspirin. It's 1,000 times more. At night, because at night there are receptors for melatonin. If you don't have receptors during daytime, you don't have receptors on the platelets. It doesn't help so much against blood coagulation. The receptors appear at night when it's dark. It also inhibits the production of thromboxane B2, maximum at 3:30 in the night. So again, a maximum in the night because there are more receptors there. And so it really decreased blood coagulability at night. This is really very good. And you never can bleed too much with melatonin. That's the advantage compared to aspirin. If you take a lot of aspirin, you can have bleeding disorders, excessive bleeding. Growth hormone treatment also has that. It decreases the excessive coagulation after just 1 week of treatment, but very high dose of 8 international units a day. So it's about 2.5 milligrams, a little bit more per day. But in 1 week already, you have improved blood fluidity. Coronary artery disease, hormone treatments, oral testosterone improves. When you give to a person, a man who has angina pectoris, 77% decrease in angina pectoris symptoms, and many other things are improved also. And then we'll talk about all these hormone treatments, but we'll also give tips what to do when a person has acute myocardial infarction. And for example, for thyroid-treated hyperthyroid patient, you might have to stop 2 days and then restart at 50% lower thyroid dose. Because the patient doesn't need so much thyroid hormones if he stays on a bed. And if the patient is not yet treated, but is hypothyroid, has a heart attack, you might have to wait 2 months before starting to treatment, just to make it safe. So we'll talk about all those cautious measures, but here you know what to do with thyroid treatment. Be a little careful when there's acute myocardial infarction. What about arrhythmia and heart failure? Well, did you know that there are hormone therapies that decrease atrial and ventricular fibrillation? For example, what we see here is that patients with atrial fibrillation, even if they didn't have it before, if they have it, they usually have lower levels of IGF-1 and lower IGF-1 IGF-BP ratio. So researchers found this as sort of general rule. And because of that, they think that actually lower serum IGF-1 to IGF-BP ratios, meaning that there's not much IGF-1 going in the cells, that's the bioavailable IGF-1, that is associated with more atrial fibrillation. And melatonin treatment, for example, can decrease arrhythmias by 47% and 84% ventricular fibrillation when rats are tested. They are submitted to an ischemia and reperfusion injury of the heart, and the heart remains quite good without arrhythmia and ventricular fibrillation if the rat receives melatonin treatment. Heart failure also, see all the studies showing low testosterone levels linked to more mortality with chronic heart failure. Testosterone therapy improves the cardiovascular function, chronic heart failure, and you see significant improvement of exercise capacity, muscle strength, ECG indicators. Stroke, also we'll talk about stroke, a lot of good information. And then we'll have patient cases, patients with cardiac and stroke or with stroke that are treated with hormone treatment. And then we arrive to the module 7, which is sexuality. And it's not true that when you get old, sexuality should decline. And we see that when children are grown up, there's again more romantic and physical love between many couples. So what you need to do as a physician is to optimize this situation so it stays good. And so we'll have a whole good lecture on male sexuality, all different problems you can have, also a lack of fantasies, a lack of drive, a lack of erection, etc. will be seen in two lectures actually. And it's really interesting because this is actually, I would say, in my experience, this is the most efficient to reverse erectile dysfunction. Of course, you can give those erectile function substances that improve erectile function, but they don't improve the feelings. And what is good is that you feel sexually stimulated and you feel good, not only have a good erection. And then there's female sexuality. And there's also a lot that can be done on female sexuality to increase sexual sensitivity, the orgasm, and etc. So we'll see the hormone therapies that improve that. And then we'll have also a lecture on oxytocin, the ABCs, and XYZs, I would say, that are really, really interesting. And then we'll have patient cases with sexual dysfunction treated with hormone treatments. And then there's, in the nutritional part, what can be done to improve oxytocin, our sexuality, male and female, with nutrients and with a better lifestyle. So let's look a bit at male sexuality. We know that men and women have different brains. We're not similar. We're different, and I personally liked it. But when you look at the men, what they have is that the brain is mostly full of sex, ball sports, but the attention span very small, ironing extremely small, and so the domestic skills very small. Of course, this is humor, but it does give the impression that indeed it's true that for men, physical sex is very important. It may also confirms in the malehood. But I can tell we can change the male brain so it keeps its physical aspects of sexuality high, but you add the romantic aspect, becomes much stronger. And so also interesting is to know is that the masculinity can be seen in the fingers. When you look at the fingers, you have to look at the ring finger of a man. If the ring finger is longer, like here, than the index, they had a lot of prenatal testosterone and they have actually a lot of serum testosterone. And usually they have a robust, prominent lower face. I have apparently a longer ring finger than the index. So this ratio is important. This gives more masculinity. And if you have a longer index than the shorter ring finger, those come in patients who had lower prenatal testosterone and lower actual serum testosterone. So they actually have, they are less masculine and they have more fragile and smaller lower face and less male features. So interesting, you can look a bit something about the past history of testosterone levels by looking at the ring finger and comparing it to the index. So we'll look at many aspects, and you know, the pleasure we have is also the erotic fantasies we can have. Don't hide yourself behind false pretenses. Erotic fantasies makes life more exciting. So why not have it? And the hormones that improve that the best in men and women are testosterone, DHEA, oxytocin, and MSH. We'll talk about that in details, but remember that you can improve with hormone therapies erotic fantasies. And here, for example, you see that men with normal serum testosterone, but who had actually 10 men were complaining of loss of sexual interest, and 10 men they improved with testosterone treatment sexual interest, but didn't improve the erectile function because they didn't have a complaint neither. In men who were complaining principally of erectile failure, testosterone did not have an effect if the testosterone levels were normal. If they had low testosterone, probably did, but not in this group of patients. Let's say with good, if you can call that, testosterone levels. So testosterone works when it's necessary and when it's deficient. Oxytocin treatment is something I really like, and I think most people like, because it makes you more emotional, more romantic, more affectionate, more extrovert. It improves also your sexual sensitivity. Life becomes a romance when you have enough oxytocin. I can tell you, my life is a romance. I have a marvelous wife that I'm very much in love with. And by taking oxytocin, it just has increased the levels of romanticism. And treatments are nasal spray. If you give a nasal spray, tablets I would prefer, but if you don't, you have that, you can have the nasal spray. We'll talk about the dosing between 8 and 24 international units a day. So we'll give a lot of practical tips. Now, male sexuality part 2, for erectile dysfunction. It's interesting to know that men with erectile dysfunction have less fitness. They also, their treadmill score when they run or they do on bicycle is also lower, much lower. So it's not only erectile dysfunction these patients have, there's some bigger problem that decreases also their fitness. And can we change the size of a penis in young boys or in men, in older men? Yes, we can if they have IGF-1 deficiency. These are syndrome with IGF-1 deficiency. It increases the testicular size. The IGF-1 treatment decreases the testis size and the penis length, the length of the penis. And then started puberty in those boys. In a 20-year-old man who was fully developed sexually, it also improved the testicle size and the penile length. So if you need to improve the length of an organ and the volume, you need IGF-1. It's not only for the genital areas, for the penis and the testes, it also enlarges, thickens the skin, thickens the hair. My hair became 3 times thicker with IGF-1. So it makes a big difference. Interesting is then when this adult, the IGF-1 was stopped, his testicles and penis returned to a smaller size. So erectile dysfunction, sometimes we see that despite testosterone treatment, it still persists. And we'll talk that it can be due to a lack of, or it can be improved by giving a synthetic derivative of MSH, male-seed stimulating hormone, that is the most powerful tool, more powerful than sildenafil and other those performance for erectile performance drugs. It's more potent to give this one to improve it. So we'll talk about this. There's dose with this MSH derivative where you can darken the skin, but there's a dose also for sexuality that's important. And we'll see that if you use them for sexuality, it's one that darkens the skin less than the other. That's called PT141 or bremelanotide. Session 3 for female sexuality. We have hormone therapies. We know that the brain is different in men and women. Let's look at the woman's brain. You see that there's a fantastic, great area for shoes, headache generator, talk and more talk, and anniversary and birthdays and impulse shopping. But driving skills can be smaller. I think this is not true. My wife drives better than I do. And I told you so gland, well, yes. So actually it's a sort of mockery, this picture of aspects in women that are often shown as being a bit excessive. And so let's use a bit that humor to tell that anyway, the brain of woman is different and a woman feels different sexuality. And it's important for her to be seducible, like in this picture suggests, but how can she be? So we'll talk about how the physical body can be improved with hormone therapy, but also how more pheromones can be, so they attract more men, for example. We'll also see that the women with strong libido are usually women with a lot of testosterone. So if a man wants to have often sex, he should have a woman with high levels of testosterone. Yeah. You see here, but how does testosterone work? Well, you give it sublingual, it works quicker, but you do see that it takes time. There's a peak level of the sublingual 15 minutes after of serum testosterone, but that's not the peak level of the effects of testosterone. The peak level of the effects of testosterone come 3 to 4.5 hours later. And then you have a maximum increase of genital arousal, of sexual lust, even of vaginal arousal with the testosterone. So it's 3 to 4 hours time lag where you get the maximum results out of testosterone. So if a woman wants to take testosterone to have more libido at bed in the evening, she should take it probably around 6 o'clock or around 5 o'clock. And then it will be maximized, not just before having sex. We'll talk about oxytocin, this marvelous hormone. And this typical woman who has not much oxytocin, she's intellectual, she's not funny, she's oversensitive to critics, but can be a hard worker. That's the advantage. They don't have time to talk about emotions, about little things, they work. So you have plus and negative things. And we'll talk about laboratory tests. Now, also about the fact that you are beautiful. Your patients are beautiful, actually, if they express emotions. Even a person who's maybe physically not the top, but if she's full of emotions, she's laughing, she looks friendly, that really is perfect thing. That makes you beautiful. So beauty is not just in the physical appearance. It is the emotions that express themselves through your physical appearance. And oxytocin is a major product behind that. It increases extraversion and openness to new experiences. 1 hour 30 later, you get a sort of maximum effect where this one becomes like this. And extraversion, openness to experiences, more positive emotions, significantly more. She is more warm-hearted, more openness to values and ideas. And she trusts easier, and she likes people more altruism. So oxytocin increases positive emotions, but has no influence on negative emotions. It doesn't make you less depressive or whatever, but it makes you more positive. So you're in a certain sense, you're less depressed this way, but it accentuates the positive emotion. And that makes you beautiful. Look how this woman and even is beautiful with her smile full of oxytocin. And so studies have shown that couples who are in love actually have a higher oxytocin level, and the higher oxytocin levels are the most they have expressed gratitude, they thank people, they thank their partner, they are responsive. The more they feel they experience love, the higher degree of love, they have higher oxytocin. It looks like they look life through rose glasses, like this woman looking into rose glasses. That's the typical effect of high levels of oxytocin. There's really a link between looking through life through a rose-colored glass, or figuratively at least, and high levels of oxytocin. So we see that new lovers usually have higher levels of oxytocin and singles not. And the more they're in love, the higher the oxytocin levels are. More positive tests affect, more affectionate touch they have when they have high oxytocin levels. So if you're of the neutral intellectual type and not very expressive emotionally, go and take oxytocin. You'll also, I can tell you, stay less easy single if you're single, because oxytocin really opens that. Oxytocin is a loyalty hormone also. Men tend to be more loyal and more romantic with women. That's what this study says. Well, I won't look into details, but this man has just taken his oxytocin. Look at how his wife is happy. So doses that are given are here. We saw already some of the doses. We also have a patient cases of patients with sexual dysfunction treated with hormone treatments. And then we have finally the last model, which is the model on obesity. We know that obesity is important. And especially appetite reduction is important with hormone treatment, and swelling and fattening of body parts due to hormone deficiencies. And you see obesity here, part 2, part 1 with different hormone treatments and also reducing hormone excesses. And then we have patient case. So we have 4 lectures how to do it with hormone therapy, including the practical cases. And then we have an additional lecture with obesity, statistics, and world heaviest persons. And then we have obesity for what the psychological addicts used to have, what physical activity does, what nutritional therapies do, and also what diets can be good to decrease obesity. So that's for the nutritional part, everything that's green nutritional part. So let's look at the hormone therapies. Appetite reduction by different ways of doing it, but also by other means than hormone therapies, is that you need to sleep enough if you want not to have too much appetite, because sleep deprived people have more appetite. They eat more. And we'll see the studies that show that. Here, among the college, short sleeping college students, they tended to eat more small meals or snacks. And the same is more or less the case if you disrupt the sleep in rats. They are more hungry and they eat more. And among those hormones that can decrease the appetite is leptin. Unfortunately, not easy to find on the market. And this is a 3-year-old boy weighing 42 kilos at 3 years. Look how fat he looks, and he's leptin deficient. He received 4 years of leptin therapy and see the difference, complete difference. He's lower weight at 7 years, 32 kilos, and he looks completely, I would say, normal, thanks to leptin. And leptin, there's a long-acting leptin actually that can give additional weight decrease compared to body weight loss of 3 kilos more. But it all depends on the dose. The more leptin you give, the higher, the better the effects. And then we'll have lectures also on different aspects of obesity and what the deficiency is behind. When you see this sort, get surgery, you get that sort of result. But basically, you can have almost the same with testosterone therapy combined to growth hormone therapy. If those are high enough and the food diet is good. We know that testosterone can decrease the fat in the thighs and the hips because we know of transformation of female to male adult transsexual. This woman became a man, like here, through therapy. And what happens is that there was a decrease in all subcutaneous fat, the skin fold thickness were decreased. Hip circumference were decreased. There was more waist to hip ratio, but you see that the hip fat area was decreased by 27% and 22% of fat in thighs. This is number 1 treatment to decrease the fat in the thighs, the cellulite. Now, you can also apply the high doses that are given to transsexuals to normal women without them becoming male by giving a blocker like finasteride that blocks conversion of testosterone to the masculinizing dihydrotestosterone. And so you can have the advantage without the disinconvenience for those women who want to remain women. Growth hormone deficiency also gives a whole change. Look at the change here with growth hormone treatment. Disappearance of all those physical signs of growth hormone deficiency and with improvements. We'll look at that in detail. Just overview, this is the fat before growth hormone, this is after 6 months of growth hormone treatment. See the change. You really decrease the fat inside of the abdomen. And so we have ACG injections, also other types of therapy. You see the change with those treatments. We'll explain details what it is, but it's a treatment that at least 2 studies showed very great efficacy, or even 3 studies compared to 5 others seeing not much difference. But the problem is that this HCG does not conserve. So if you use HCG and it doesn't seem to work, it could be that you're using a product and you're mixing the powder with sterile water, which doesn't protect against bacteria. So you need a bacteriostatic solution. And 3 months of subcutaneous recombinant HCG was given, and you improved the lean body mass and increased the fat mass in older men with partial androgen deficiency. So it works probably more in men who have androgen deficiency, because HCG can increase testosterone production. It increased the testis volume, decrease the testis volume. But look here, what is interesting, it also can increase estradiol. So you usually need to give with HCG an aromatase blocker, a blocker of the conversion of testosterone to estradiol, because otherwise the man can feminize. Then we'll have patient cases with obesity treated with hormone treatments that will illustrate our things, and etc. So here we arrive at the end of the presentation. I think you have the idea is that you are healers, and you need to treat the cause first before treating the consequence. Too much in medicine have been taught, treat the consequences. Somebody's headache, give an anti-headache medication. Somebody is tired, give an amphetamine or whatever. Fortunately, that's not too much applied, but there are some physicians who apply. Now, treat the cause. And the cause, when it's recurrent or chronic, is probably hormone deficiency, maybe also nutritional deficiency. And so give what is necessary to the person. And there's often, it's multifactorial. So let's look at the programs where you can get the information. This is cycle 2 that I explained. In cycle 1, you had a lot of very interesting information, very accurate, still often not enough applied, but you already have all the tools to overcome the COVID infections, and also even to prevent actually some of the problems that are with the vaccine of the COVID, and to stimulate the immune system in general. What we should do against the COVID is, and all infections, is improve the immune system. We know that the vaccine against COVID doesn't hold on long. The antibodies decrease again after 6 months or something like that. Well, people who had the COVID, the infection, have longer antibodies because they created a better immune system. But why not, without having disease, have a better immune system? So inflammation and inflammatory disorders, model 2, model 3 is reversing physical aging. This is the one who was actually the most successful of many physicians just subscribed to this one, although all of them are very interesting. Female hormone supplementation, really interesting. Chronic fatigue and burned out, very interesting. That's probably the very interesting part for nutritionists also there, but also the hormone treatments that improve, that decrease fatigue and increase energy. Thyroid diagnosis and treatment, melatonin deficiency diagnosis and treatment, testosterone deficiency and diagnosis and treatment in men and in women. So these are all the models. And we have now for our Spanish friends, the first 4 of those already translated into Spanish, and next models are going to be translated in the future. You really can become an expert. You have information here very actual, updated, and you also have older information that has forgotten, but is necessary to know. With practical dosing and tips, really interesting. This cycle 1, and then the cycle 2 is the one we just saw here, where we saw this into details, but we don't yet have the Spanish subtitles of these. Discover the new nutritional program. That's cycle 1. That's a whole section of the nutritional section of cycle 1. And has a lot of interest and really contributes to make it better for you. Our next events, save the dates. We will have a question and answer session for those who are registered in cycle 1 or cycle 2 on September 24th. And on October 12th, there will be a free overview webinar on the hormone therapy consultation. I give already some slides here. We'll make it a little bit more extensive, and we'll have more time for question and answer, and we'll try to have another doctor also being interviewed to make it even more exciting. But this hormone therapy consultation program is really, really interesting because it's the base. It gives all the overview that you need to know when you do hormone therapy. And so this will be the next free webinar live. You can register here by scanning this. If you have your phone now, you can just put your phone against it and you can already register in this way. Time is here, 8 p.m. Brussels, that's 11 a.m. Los Angeles, but you have different hours that will be given for that. And then we have here on I think it's Tuesday, September 21, Isonut Academy is giving formation for physical exercise, I think, and all these things, but my Spanish is not optimal. So read it if you're, it's online, it's in Spanish, and Isonut is a very good partner of us. For promoting here. And then we have the books for those who really want to get experts. I really recommend, for physicians at least, the Hormone Handbook, the Testosterone book, the book on reversing physical aging, and the Atlas. These are really the 4 books that will be the most helpful in your practice. And if there's one book you start, this is the second book. And then these are other books you do later if you're not buying the whole package. So you can go on this, you just put your iPhone here or your mobile phone here, scan that, and you get to order these books. And here are books more for general public, but some like Patient, Sex, and Long Life will be also interesting for physicians on a cheaper price. So you can do that. Then I want to really thank my partners, Nutritional, Jakarta Anti-Aging Center, LIMS, Ivan Mirpuri in Portugal, Saham in Malaysia, Your Health, the VIP Pharmacy in Argentina, Now Diverse Products in Canada, Pharmacy and Compounding Lab, Sweet Trade, Access Laboratory, really very good, Diagnostic, Labo4, Nutricia, really helped IRFA, Canada, Laboratoire Optim, and Energetica Natura, Qualivita in Barcelona, and Forsthaus Apotheke in Germany, Nutri Essentiel in Belgium, Biosil, Bionoriso, really helpful for the Spanish translation here, University Compounding Pharmacy, and all these, the Vital Plus also, an NP Compounding Pharmacy in Greece, a great guy, really, and Isonut that we just mentioned, Laboratoire Copmet also, Longevidade, Saudavel in Brazil, that's the #1 group in Brazil, working on hormone therapy in the VIP Pharmacy also. So we have here all the ways you can follow up things. The focus we have is to help people. And I can treat more patients by training more physicians. And the idea is the more physicians get the information, the more patients they can treat. And then I would say my destiny or my duty is done. And I have a great pleasure of sharing the information as much as I can. So we have the Facebook. And if you need any additional information, we're going to have question and answer session going to follow now. We have the Hertoghe Medical School.eu. That's the website. And then if you want any question, you send it to office, my family name, Hertoghe.eu, office@hertoghe.eu. Thank you for your attention. So any questions, I'm going to stop sharing the screen and I'm going to look at the question and answers that you have put here. We'll look first at the chat, the question and answer session. Here's Gunnar from Sweden. As a patient in Sweden, it's almost impossible to get an examination from an endocrinologist. You need to get a general practitioner to take correct samples. but they lack the knowledge of how to do it. So what pills do you recommend the doc should take to be able to write the correct referral to an endocrinologist? Growth hormone, testosterone, estrogen, DHEA, etc. Well, of course, it's a little humoristic is that as the doctors, general practitioners who have to give a referral for an endocrinologist, because in that country it's sort of a hierarchical system, why do the doctors not take the treatment? So if they don't take a treatment, they make a prescription and referral. And I'm sorry, Gunnar, you probably, I don't know a Swedish doctor that does referrals for endocrinologists, although because the medical board system is very old-fashioned. You have to go to Belgium or you have to go to another country in Europe where physicians are more open. Belgium is probably the best. England, and there are some physicians apparently that do some, but in France it's completely impossible. So you'll have to go elsewhere. Have you published any article on how a correct sampling investigation is done? No, I have published a book. So my book, Hormone book, and gives exactly the test you need to do for each hormone deficiency. And there's a version for the patient that is cheaper, is called the Patient Hormone Handbook. So why not buy that book and have that? Okay, so then does DHEA have to be taken at the same time as cortisol, or can you take DHEA later in the same day? DHEA converts when you take it orally, not sublingual, or if you take it orally, you swallow it, it will have a 24-hour effect. So you can take it at other times of the day. The important is that you take it daily, every day. And then you have adequate levels. But that's one of the exceptions. Normally, many hormones have to be taken in the morning, but you can take possibly DHEA later than cortisol if you take cortisol. Here's Jaber says, can DHEA, prednisolone supplements impact pregnancy or get pregnant? There are studies showing that women with high levels of DHEA get easier pregnant. So it seems to increase the fertility. And I had testimonies of a gynecologist, a friend gynecologist, who gave, each time he gave DHEA to women who couldn't get pregnant, they got pregnant. So he was very surprised and enthusiastic about that. Pregnenolone won't be a problem. It's almost sort of cholesterol you give, so you can give it, but it will improve the short-term memory of a woman who is pregnant but won't have any adverse effect. Prednisolone supplements is a synthetic derivative, can only be given during pregnancy if a woman has cortisol deficiency. And in that case, I prefer to give during pregnancy if the person needed prednisolone, a synthetic derivative for inflammatory reasons, before the pregnancy. During the pregnancy, I would rather provide hydrocortisone. Now, hydrocortisone improves fertility, improves ovulation. So even if one wants to get pregnant, couldn't get pregnant, but has adrenal deficiency, cortisol deficiency, provide the bioidentical cortisone, hydrocortisone. That would be a better, and she will have a better ovulation, thus get more chances of being pregnant. During the pregnancy, if a woman needs cortisol and she doesn't receive it, she's cortisol deficient, she gets a lot of vomiting. She vomits easier. And she has easier miscarriages. So by giving cortisol during the pregnancy, you have less risk of miscarriages, and you will also much or totally decrease the tendency to vomit and the nausea. Then Suhaya, does pregnenolone at night is efficient for people who work on night shift like 7 p.m., 7 a.m., for example? If you work on a night shift and you take pregnenolone is a stimulating substance for the brain. So basically, you will probably have a better memory and a better function. But the important is you take pregnenolone before you need to use it. If you're really going to sleep at night, don't take it at night because you don't use it, and it has a sort of 12-hour effect or a 10-hour effect. So use it when you at least have 8 to 10 hours of being active after, so you need to use it. Does Mario, does it only improve memory in schizophrenia patients? No, I take pregnenolone every morning, for example, and improves my short-term memory. So I go in another room. I have a very sharp memory. I know always what I'm going to get. I don't forget. But if I don't take pregnenolone for, let's say, several days, then back I have short-term memory loss, and I have to make an effort to think, what have I been, why did I come there? So it is works in I would say everybody who has short-term memory loss, not long-term. And then here another person says, after only 6 weeks of growth hormone treatment, my skin became very dry and much more saggy. What would be the problem? Blood estrogen levels were very, very low. I'm a 69-year-old woman, so stop growth hormone because of skin, but should it be, it's very strange that growth hormone would give a dry skin. So maybe something else happened, but now growth hormone can improve the skin only if there's enough male hormones, testosterone, and enough female hormones, because it has a stimulating effect. It decreases sex hormone binding globulin, and the sex hormone become more active. And so if you want to have a less dry skin, you need more sex hormones. So you should, as a woman, treat your estrogen deficiency and progesterone deficiency and testosterone deficiency. And then you will probably have a much better skin. Now, if your skin is very dry, I suspect that if it's rough, there's low thyroid. I mean, there's sort of keratosis with rough. But if it's very soft but flaky, that's a lack of omega-6 fatty acids. So you need borage oil like 3 or 4 grams a day to correct that, or thyroid hormone. So think on all those hormone deficiency to improve that. Again, Jaber, do we have to supplement FSH and LH at men? In general, you don't have to supplement FSH and LH in men, except if you need to improve fertility. Then you need to have an FSH-like substance, and what is then given is HCG. HCG has the same efficacy as FSH and LH, and it's much cheaper than the very difficult to buy and expensive bioidentical FSH and LH that have been made by biotechnology. So basically, you can supply HCG when there's a fertility problem. You need to improve spermatogenesis in a man. Marvin says, need to leave, but very interesting in your program. Okay. Gunnar, again, are the following symptoms common or unusual? I've never had a failing erection, sometime until the age of 61, when the erection decreased sharply for 6 months, for the point that is almost impossible. When in a man, an erection collapses after 6 months, everything is reversible, and he should take the testosterone. The growth hormone gives erections of longer duration, and maybe even MSH or melatonin 2, that is unfortunately not in pharmacies in Sweden or in European countries, but is sold half legally on internet for experiential experiences. So can we use oxytocin in men in the same dose? Yes, of course, oxytocin is good for men and women. The doses ideal is if you can have a pharmacy, they can make sublingual oxytocin efficiently, like 5 or 10 international units. That's the best. Otherwise, you take intranasal oxytocin between 1 to 3 sprays a day, which is 8 to 24 international units a day. Here, Marley says, is it possible to take several hormones at the same time? For example, oxytocin and growth hormone. Yes, it's possible to take several hormones together. Most of the hormones are taken in my patient in the morning or in the evening. Now, oxytocin, I would rather take it in the morning or in the evening before the meal or after the meal, because you're going to have sex in the evening, for example, or going to go to party. So it's better to take it before the party. You will have a better party, more extrovert, more friendly. But growth hormone is given before bedtime. So I wouldn't necessarily take at bedtime oxytocin, because then you don't need it, or if you need it, you take it 2 hours before sex, but not just at bedtime. You're really going to fall asleep. While growth hormone should be taken just before you fall asleep, ideally. How to select the initial and subsequent hormone therapies? If thyroid, so normal thyroid, do you still treat thyroid or move forward to adrenals? So which are the first treatments to give? In my hormone handbook, I specified and I really give the order. And the order that I gave there is first learn about thyroid hormones and the sex hormones. So if you do it first. And that's also how do you do it with patients. And then learn the adrenal hormones like cortisol, DHEA, etc., and melatonin. I personally, when a patient comes to my consultation, they come from far, it's very extensive consultation, more work is done, etc. I give a lot of treatments at already the first consultation when I had all the lab tests and did the physical exam. And actually it works better. They have quicker results, better results, and more balanced. So actually the more hormones you give, because they are hormone deficient, you're correcting, often the safer and more efficient the treatment is. But in generally, if you are a starter, I would say learn about thyroid function, learn about the sex hormones, and first try to correct those deficiencies in your patients. And the next step will be adrenal hormones later on. Venom, are there any hormone treatments for overactive bladder? So overactive bladder is going often to the toilet. Well, first you have to see if it's a real overactive bladder, because maybe the problem is that you always have to go to the bathroom and you always urinate large volumes. So you're losing water in the kidneys, in the bladder. And that is due to vasopressin deficiency or aldosterone deficiency. So you need to correct those deficiencies. But if it's an overactive because you're nervous, all the hormones that calm you down, like growth hormone and melatonin, will calm that down. And many of those patients with overactive bladder, they have a sort of mixed syndrome. And so they should take some vasopressin before bedtime, for example, or during the day, or if they go on travel. And they should take calming hormones like growth hormone that calm you down, and melatonin at night, and that calms down. But overactive bladder has always some, when it's really chronic and recurrent, some hormone deficiency behind it that you need to correct. In Sicily, I'm a herbalist and functional medicine practitioner, not an MD. What is the best way to help my clients with hormone deficiencies, since I won't have access to all the hormones for treatment? Use the hormone cofactors, precursors. Well, yes, in a certain sense, the best first is to improve the food. You can already improve hormone levels by 20 to 30% by better food. If the patient has bad food, you will have an improvement there. That is important. And then what you will see, as in the nutritional therapies, there are several nutrients that really help to improve hormone levels if they are low. For example, if zinc is low and testosterone is low, in older men, you can almost double the level of testosterone just by giving zinc. So you can give with nutrients and make a difference. That is important. I also think that sleeping is very good. If you make them sleep more, they will have better stores of hormones, etc. Most people are always borderline. They do a maximum and they take coffee, so they lose minerals. So they should stop the coffee so they don't lose the minerals. And they don't sleep enough. So if you make people sleep more, they will have better hormone levels. And there are some herbs that also help, like maca, for example, that mimic the effects of hormones and that have something between a 5 and a 20% effect of the hormones. So even that is important, because you add everything. The diet is improved, nutrients and herbals, and you get quite good effects, maybe 50%. Okay, they're saying we're going to stop nearby, so I'm going to try to answer here to some of the last questions. Do you have any recommendation when you have Parkinson, hormones that can reduce the symptoms? Well, the trembling is difficult to reverse. You can stop further aggravation by hormone treatment. And especially it seems that coenzyme Q10 at extremely high doses, 1500 milligrams per day, can be tried to see if it really decreased the trembling, because there there are anecdotal evidence that it really helps. But in my experience, I reversed several Parkinson's by giving high amounts of growth hormone and giving the testosterone, the thyroid, etc. But the growth hormone was the critical factor that reversed the dementia and the premature aging of Parkinson's. So you can do a lot. Ideal is, of course, to come in a consultation and follow the treatment well. The food is also important. Why do doctors in UK shy away from prescribed ephedrine, omnitrope, finasteride, and nirogacestat? Well, the thing is that in UK, the national health system is a very bad system, I would say, because it's very rigid. You may not do something out of the box. You have to do everything in the box. And ephedrine, omnitrope, finasteride, nirogacestat are not in the box for men, for example. So they risk sanctions. So even if they are open, they have a certain fear. And I know physicians, I've several times have had to defend physicians, and I can tell it's stubbornness in those medical boards. Even hard fact, scientific evidence, they are not open. Even if their own expert, a professor at university, changes board and agrees with me, they don't accept that. So it's very, you have to go in other countries if you don't find relief. I think there's in London some doctors that apparently are open for it, but I don't know them personally very well, so I cannot. I'm not sure if it's okay or not. Which pregnon would you recommend? I think most of the pregnon you can have is good. Here, Harlan from the States, I think. Do you consider nitric oxide a hormone? No, I don't consider it hormone. It's more like a nutritional supplement that can be very good for the heart. Is it possible, that's in Spanish, to reverse masculine hypogonadism secondary to intoxication by products of washing? Of course, all pollutants can cause damage to the endocrine glands, and that damage is partially reversible by optimal diet, by drinking a lot of water, avoiding the pollutants, and providing the hormones. For example, if you provide thyroid hormones, that will improve the blood flow everywhere. Also in the capillaries, you're going to wash away the products more, but you need to drink enough water so it doesn't go on other tissues and goes inside of the urine. Another question in Spanish. The treatment is, can the treatment of oxytocin provide high blood pressure? No. Low blood pressure, yes, because it's vasodilating. It contracts the uterus, but all the rest, coronary arteries, vasodilation. So it gets vasodilation. So you shouldn't be afraid of hypertension unless there's a sort of paradoxical reaction but that would be exceptional. I haven't encountered that. Can essential oils treat hormone deficiency? Essential oils, I'm not so familiar, so I cannot give an answer, but I never saw a patient improve sufficiently for hormone deficiency with essential oils, because I have patients who do try other things. So I think essential oils are good antiseptics, are good for many, many things, but it's not enough. When you have a hormone deficiency, you should get the hormone. And you can additionally give an essential oil if you think it can improve. But in my knowledge, I haven't encountered that those are the treatments of hormone deficiency. I would say it's a weak treatment if it is a treatment, but it's a good treatment for many other things. So I'm positive for essential oils. But when you have hormone deficiency, try really to treat the hormone deficiency if you can. That's the best. Okay, I'm going to stop here. There is in October another overview lecture. I thank you for all your questions. I thank you for assisting. I think those who will prescribe for the cycle 2 will be really happy. But I'm happy of being with you today. So thank you for being there. I want also to thank my whole team, because you think I'm doing all the work. That's not true. I have Isabel, who is our happiness energy in the group, who leads the team that you will probably have if you contact her. We have Sarah, who prepares all these technical things. We have Mehdi, who helps especially with these lectures. who is really a good help. We have Sylvia who prepares the slides. I have my wife who is not only my fairy, but is also the fairy in the projects with the new projects. So really have good people. I'm always very happy of all the doctors that work with me in the clinic that really increase my insight. I'll talk about them next time, focus a little bit on our team here. But the secretaries like Cecile and Natalie are doing also a great job. So don't hesitate to contact one of our team members. They're great people. Thank you, and thank you. Have a nice time. Bye-bye.